One sec, YouTube. Let me just get Facebook started here. Excellent. We are good to go. All right. Hello, my friends. It's Jill Osborne from the Interstitial Cystitis Network. It is Sunday, October 20th of 2024. It is time for another live IC support group meeting. I was not here last weekend because I just was not feeling well. You know, I am getting a very, very big lesson right now in the importance of taking time to heal and de-stress. And even though my breast cancer surgery was 3 months ago, it still catches up to me every now and then. And so I did not feel well last weekend. So thank you so much for your patience. I am here, praise God. I was praying this morning for God to help heal me so that He could use me, because I know that when I do these meetings, I have a chance to help others. And that's always, always, always my goal. So my name is Jill Osborne. I'm the president and founder of the Interstitial Cystitis Network. I'm the longest serving IC support group leader in the United States. And at this point, I'm pretty much the world. Might be one person who's been doing it longer than me. Maybe not. Hard to say. I bring to you a bunch of college degrees. This is my job. I've worked with IC now for over 30 years. I do IC research. I write IC books. I do presentations at medical conferences. I've got one coming up next month. I'm currently serving on the AUA guidelines panel for the development of guidelines for male pelvic pain. And so this is my job. But truly, the best part of my job is working with you. And the best moments of my job are when I get to say to you, you're not alone. You've done nothing wrong. I don't want you carrying any shame or any blame about what you're going through right now. You have pelvic pain. You have been injured. The vast majority of IC patients now we recognize are actually injury patients as compared to a bladder disease patient. Hello. So right now we're simulcasting. So when I'm looking this way, I'm looking at Facebook. When I'm looking this way, I'm looking at YouTube. And so hello, James from England. I think I remember you. I got a pretty good memory despite my age. Here, hold on a sec. Let me fix this camera here. There we go. Get that right for YouTube. Hello, Gay. It's so nice to see you. Now, normally when I do these meetings, I do a little educational blurb first, and then I'll take your questions. I go as long as you have questions. And so sometimes we go an hour, sometimes we go 4 hours. It's entirely up to you. Whenever you visit my website, the Interstitial Cystitis Network, I always have one very, very clear goal. I want you within 5 minutes to hear something or read something that will help you get through the day, that will give you hope, that will give you comfort, that will give you encouragement. But really what we're trying to do is find the underlying cause of your pain so that it can be treated successfully. And that's what I'm going to talk about today. The IC movement is transformed. In the last 5 years, it is completely different from what it was 10 years ago, 15 years ago, 20 years ago. Because 20 years ago, we were all operating under the assumption that we all collectively had an incurable bladder disease. And so all of our treatments back then were focused on the bladder. All of our testing was focused on the bladder. And here's what we know. Bladder treatments really didn't work for most of us. Didn't work for me. Hello, Sylviane. Thank you, hon. Um, Bladder treatments, when you look at the actual research, barely perform above placebo. Sometimes they're placebo, sometimes they're slightly above placebo. And back in 2008, we had an event which turned the IC movement on its head, and it was triggered by a fabulous physical therapist named Rhonda Cotterinos. So Rhonda Cotterinos came to a National Institutes of Health IC meeting that I was at. And she said, "Hey guys, you keep describing muscles so tight, they look like piano strings, but what are you going to do about it?" And they were like, "Oh, no biggie. They just have tight muscles." And she, a bold, strong woman that she was, because it's all to me, I'm very focused on making sure that women's voices are heard. She prevailed. And she said, "Well, I want to share with you what's happening with my patients, because when we work on these muscles, their bladder symptoms get better, dramatically better." So much so, she invested her own money to go to the conferences. Well, of course, they blew her off. You have to understand, urology is fairly macho. Urologists are surgeons. Doctors that are attracted to urology as a field are often the best surgeons, because it's very intricate surgery to work in urology. And so they're pretty macho overall. And so here you've got this young woman coming in and saying, "Hey, have you considered the muscles?" And they were like, "Nah, no biggie." Well, she was persistent. She came back the next year. And I think she probably provided some data. It's hard, I don't remember exactly because this was some time ago. And they put her on the agenda. They put her on the agenda. They gave her the last speaking spot of the day. And she valiantly got herself up to the podium as literally half of the guys walk out. Half of the urologists walk out. But she persisted and she shared her information. She shared her finding that many patients with interstitial cystitis have very tight muscles. And when you work with these muscles and you get these muscles to release, benefits happen. The blood flow improves, oxygenation to the bladder improves. So she planted a seed, a good seed. But then it went one step further, because at some point in time, the National Institutes of Health agreed to do a research study to see if physical therapy truly was helpful for the IC patient. So they did what we call a multi-center study. So at research centers across the country, and they had patients do either pelvic floor myofascial massage or they just did plain massage. Well, that study came out a year or two later, and that showed that pelvic floor physical therapy was stunningly successful. So when you think about the research results for the bladder treatments, you're talking in the 30 percentile. The research results for the pelvic floor physical therapy were in the high 60 to 70% success rate. So this was a pivotal moment in the IC world, because at that point in time, the leaders in the IC community around the world went, "Uh-oh, oh, wait a second. How can this be a bladder disease if physical therapy helps?" And that was the moment that turned the IC movement on its head, because that's when the moment when everybody went, muscles must be involved. And again, if you go back to those early papers, they describe muscles so tight, they are like tight piano strings. And of course, back then, we're talking 10, 12 years ago, 15 years ago, we didn't have trained physical therapists. So we faced another challenge, and that is, okay, you might have had an enlightened doctor send you to physical therapy, but if you went to a physical therapist who hadn't been trained, they would have told you to do Kegels, which of course make tight muscles worse. So we've had this decade-long learning educational curve where we had to start training physical therapists and how to work with the pelvic floor, because pelvic floor therapy is internal. It is not external, it is internal. It is done through the vagina or done through the rectum, because that's the only way you can reach these muscles, my friends. So today, now we have more than 10,000 physical therapists across the United States who have been trained in pelvic floor work, with quite a few fully certified with this new pelvic floor certification that they've created to make sure that these physical therapists have the proper training. So if you go to a physical therapist who says you need to do Kegels, they're not trained. The last thing we want to do is something that will make muscles even tighter. Kegels are appropriate for incontinence. Kegels are not appropriate for muscles that are already very, very tight. And if you look at our national IC guidelines, they very clearly say that patients should not be given Kegel exercises or things that will tighten the pelvic floor. The other thing to understand about our national guidelines, which were last revised in 2022, there's only 2 recommendations. Now, recommendations are like the full weight of the urology community say, you need to do this when you work with patients. Recommendation number 1, when you have a new patient at that very first appointment and you're doing that evaluation, check their pelvic floor muscles. If their muscles are tight, you are to send them immediately to physical therapy. And the second recommendation in the guidelines is, if you suspect Hunner's lesions, please look for them. And if you find them, treat them at that time. Those are the only firm recommendations in the guidelines. Everything else are options. Okay, all the other treatments are optional based upon how you present. Okay, so big change number 1 is the recognition that muscles play a big role. And now what the research shows is that 85% of the IC patient population are actually neuromuscular. The great majority of us are neuromuscular. So then some of you say, well, then why am I bladder sensitive? Let me tell you why. The reason why you're bladder sensitive is because you're in a state of ischemia. Ischemia means the blood supply is compromised. If the bladder is supposed to get 24 units of blood a day and it's only getting 10, are you going to have a healthy bladder wall? No. There's a devastating toll to tight muscles that over time, what do? They squeeze nerves and they squeeze blood supply. So our therapeutic priority for the pelvic floor patient is to restore blood supply. And the way we do that is to get the muscles to release. Okay. Now, 5 years ago, give or take a year or 2, we had Dr. Christopher Payne say, hey, yeah, there's definitely a group of patients who have pelvic floor. There's definitely a group of patients who have Hunner's lesions, but there are other groups too. And he argued when his proposal about, he was the one who first proposed phenotyping for IC patients. He said, we need to treat IC patients like cancer patients. And of course, I'm like going, oh my God, don't say cancer and scare people in my brain. All the more relevant now, given my year. And he's like, no. I'm not saying IC is cancer at all. He's saying, listen, when somebody's diagnosed with cancer, they don't just say you have cancer and send you on your way. They give you a very specific diagnosis. Jill, you have cancer in your left breast, ductal carcinoma in situ, stage 0. Your treatment options are this. Okay, true story. that when you are diagnosed with cancer, you are given a very, very clear treatment plan. And he argued that a diagnosis of IC does not do that, that when a urologist tells somebody they have IC, both the urologist and the patient really, honestly, don't have a clue what to do next. And a lot of you just start throwing everything at it. Man, you're doing supplements, you're doing treatments, you're doing installations, you're doing surgery. You're just like throwing the bathtub at your symptoms without understanding the entire point that Chris Payne was making, is that we are a diverse patient population with distinct patient groups, and each group has its own treatments. And to waste time doing bladder treatments when you've got pelvic floor makes, now we know why so many patients didn't respond, like me. So he said, hey, let's start phenotyping patients. And then based upon the phenotype, we can give them a much more individualized treatment plan. And so he proposed 5 phenotypes. And this is the system that I use when I work with patients when I'm coaching, okay? So in his system, he believes that Hunner's lesions are a distinct group. Everybody in the world believes that because Hunner's lesions really are a disease. It's 5-7% of the IC patient population have wounds on their bladder, visible wounds on their bladder. And those wounds have now been connected to viral infections, the Epstein-Barr virus. So that's one group. And obviously for that group, our treatment's going to be focused directly on how do we get that wound to heal. And of course, that patient's going to be very, very diet sensitive. Phenotype number 2, bladder wall driven. In this group, we look for 2 things. We look for a chemical injury of the bladder. So if your symptoms began while you were going through chemotherapy, if your symptoms began because you were drinking a massive amount of diet soda, or energy drinks, listen, the bladder was designed thousands and thousands of years ago before today's concentrated acids. The acid in our diet today is phenomenal, and it eventually is going to take a toll. Okay. So if we have somebody who's got a chemical injury of the bladder, how are we going to treat it? We're going to find the chemical that's irritating it, try to get rid of it, whatever it is, which means some of you have to give up your coffee for a while and give the bladder time to heal. Because healing is always happening. Healing doesn't turn off. The majesty of the human body is every second of every day, it is trying to fix whatever's going on. The problem is we get in the way. One of the ways we get in the way is by pouring acid on a wound every day, because the wound's not going to heal. Now, the second thing we're going to look at in this group is we're going to look at estrogen levels, because the way the bladder protects itself is with a really thick coating of mucus. Your bladder is like your mouth. It's a hollow organ that's wet on the inside, and that mucus acts as a barrier. It's thick, it's robust. It pushes urine away from the fragile cells and the nerves. It's what we call hydrophobic. It pushes water away. It pushes urine away. Unfortunately, this nice thick mucosal barrier is estrogen dependent. So when you're young and have a lot of estrogen, you're good. If you're on birth control, if you're on Lupron for endo, if you've had a hysterectomy, or if you're just getting older, you don't have the estrogen anymore, or as much, which means you don't have as much mucus, which means your bladder's ability to defend itself is now greatly compromised. That's not a disease. That's what we call estrogen atrophy, or the genitourinary syndrome of menopause. Now, some of you have been told you have an incurable disease. It is not a freaking disease. It is just dryness. And our therapeutic priority for this group of patients is to try to give the skin what it needs to produce its own mucus. And what is that? That is estrogen, topical estrogen. This is not systemic estrogen. This is topical estrogen that goes right on your skin. Topical estrogen is much, much, much safer than oral estrogen. The most natural thing you can do is give your body estrogen so that your body can produce its own natural mucus. Of course, you're never going to have a 20-year-old bladder again. So you might benefit from something that will help protect your bladder and coat your bladder. And this is where the old medication Elmeron was used and probably the most effective because it was basically a chemical band-aid. But now we know Elmeron is associated with some pretty serious eye disease. Patients, many of the lawsuits have settled now. I worked with a patient this week who got $500,000 from the lawsuit because of what Elmeron did to her eyes. So Elmeron is no longer a first choice. Instead, we're probably going to look either at heparin installations in your bladder, or we're going to look at some of the supplements that I've got up on the back wall, something like Bladder Builder, Bladder Rest, Cystoman, Cysto Protect, that have chondroitin in them that will help to coat the bladder. Okay. Our third phenotype is our biggest phenotype by far. These are the patients whose symptoms are caused by tight pelvic floor muscles. These are symptoms. So these patients, their onset will be related to an injury. Like for me, I fell and broke my tailbone in 7th grade, and that's when my symptoms started. Or after having a baby and suffering a 3rd-degree tear, like a patient that I was working with on Friday. Of course, you don't know you have, Mare, hold that tight. Yeah, hold on, honey. I'll get back to that. Of course, for these patients, you have bladder symptoms. You're peeing every 20 minutes. You're going, it's impossible. It has to be my bladder. And so you do bladder treatments for a year, 2 years, 5 years, 10 years, 20 years. The problem is you're still flaring. You're still symptomatic. Why? Because bladder treatments don't fix tight muscles. And until we get the blood flowing again, that is a problem. We've got to get the blood flowing so that the bladder gets enough oxygen and nutrition so that the bladder wall can be healthy and have a chance to be repaired. So we call this ischemia or ischemia. Mare makes an important point. Mare says, topical estrogen is not for those who have had estrogen-fed breast cancer, HER2 plus triple positive. Thank you for clarifying that. You know, my journey into breast cancer is new, and I'm reading everything I can. But that is definitely a worst case scenario. And there certainly are going to be some patients with cancer who have to have a very good, close discussion with their oncologist, just like I did, about how they use their estrogen. Because my oncologist said, you can use it. So anyway, important clarification. So phenotype number 3, pelvic floor driven, we now believe that that's 85% of the IC patient population. But you can have multiple phenotypes. So our next one in the Chris Payne system is pudendal neuralgia. So these are patients whose muscles are so tight, they're squeezing nerves. So think about sciatica. Sciatica is proof that you have a tight muscle because the piriformis muscle is squeezing the sciatic nerve, which is giving you that shooting pain down your leg. So these patients have positional symptoms. They're fine when they stand, but when they sit down, it hurts, or when they bend over, it hurts. So I always ask patients when I'm working with them and we're trying to phenotype them, does your pain get worse when you sit down? Does it get better when you stand up? That's a clear sign that we've got very tight muscles now squeezing nerves. Another symptom of pudendal neuralgia is going to be pins and needles, areas of numbness. Patients with pudendal neuralgia really prefer ice. Patients with tight pelvic floor muscles prefer heat. Ice calms nerves, heat relaxes muscles. I have a pudendal neuralgia on the left side of my tailbone, about 1.5 inches away from it, that if I sit too long, quivers. It's doing it right now. It's like, it doesn't hurt, but it's very annoying. I've had it, oh my gosh, how long have I had this? For probably a decade now. S- Um, so that's because my piriformis muscles on my left side stay very, very, very tight because they're trying to stabilize my SI joint. And as part of that, they're then squeezing nerves more frequently than other people. One of the questions you ask your physical therapist to see how you're doing is, are my muscles responding to therapy? Are they slowly getting better? Or are my muscles always locking back down into tension no matter what you do? If your muscles are always locking back down into tension, that's a problem, because what that means is that you're like me. That means that there's a bone problem. You might have a tailbone that's crooked. You might have an SI joint that's unstable. You might have a hip that's funky. If you have scoliosis, you might have one hip rotated this way and the other hip rotated this way. If you have one leg longer than the other, you're going to have one hip higher than the other, one lower. And so when you walk, you're stressing your pelvic floor. We're going to look at your knees. Are you limping? But most importantly, we're going to look at your feet, because Dr. Jerome Weiss, and he was the first urologist to really get into muscles and become a true master at all structures in the pelvis that can impact the bladder, particularly the muscles and the nerves. He was fascinated by the fact that no matter what he did, there were some people whose muscles just locked back down every single time. And 95% of them had a bad foot. So all those forces of when you walk, the missteps, the stumbles, are directed right back up your legs, right back up your knees, right up into your hips, and right into your pelvic floor. So if your foot is not hitting the ground correctly, if you're pigeon-toed, if you're duck-footed, if you have an ankle that rolls in, ankle that rolls out, that's going to affect your pelvic floor. Okay, our fifth phenotype is now the most important and newest phenotype that is critical for you to understand. So these are the patients who have multiple pain conditions. You got the bladder, maybe some IBS, maybe some vulvodynia, maybe some irritable bowel, maybe some fibro, maybe some chronic fatigue, maybe migraines, maybe TMJ. So I'm in this group too, because I've had almost all of those at one point in time. So what is that about? Well, we now call that chronic overlapping pain conditions. And this is about 40% of the IC patient population. And remember, you can have multiple. So I'm pelvic floor widespread pain with a little tiny bit of pudendal neuralgia in there. So widespread pain is the reason why pretty much every IC research study has failed. We have a Dr. Phil Hanno, when he was introducing AUA guidelines years ago at the big National American Urology Association conference, he just flat out said to hundreds of doctors, hey, we invested $100 million in IC research, every study failed. Why? Well, because you can't put apples, oranges, and bananas in the same study and expect success. And there's one patient group in particular that's very, very challenging. And that is those of us who have widespread pain, because widespread pain is actually a problem with the central nervous system. It's an injury to the central nervous system. So patients who have widespread pain have very sensitive skin. I do. You might have a wicked sense of smell. Your hearing might be very, very sensitive. I can still remember with my sweet Sammy, who I had for 20 years, a sweet little calico kitten, little tiny cat. Actually, you guys saw her in my stream. So she used to come in all the time before I lost her in 2017. I could hear her meow anywhere. Even if she was stuck in the neighbor's garage, I could hear it. That was so weird. So, several years ago, all the affiliated groups, came together and said, we need to figure out, why do some people get widespread pain? And they created something called the Chronic Pain Research Alliance. And it's a Chronic Pain Research Alliance, which is still active today. Really a fantastic research team. You can Google it. You can read their research. You can sign up for their newsletter. They're the ones who started looking at nerves. And they looked at nerves in the skin. They looked at nerves in the spinal cord. And then finally, they started studying the brain. And I didn't talk about it for a couple of years because I thought this talking about the brain would scare people, when there's really a happy ending here. It's nothing to be scared of at all. But here's what they found, and other researchers have found. Patients who have widespread pain, when you look at our brain, you see constant chronic fight or flight. There's a structure in the brain called the amygdala, which is only supposed to turn on during periods of intense stress. Like if you see, like we just got off of a red flag fire alert, which is never fun here in California. If I were to see a fire, or if I even hear the alarm for a fire on my phone, believe me, I go into fight or flight. My amygdala turns on, and what does it do? It increases my heart rate, increases my blood pressure, it tightens my muscles to prepare me to respond to what could be a major wildfire. But of course, it's 2024. I call the fire department. They come out, they put the fire out. An hour later, the threat is gone. And when the threat is gone, fight or flight is supposed to turn off. But for patients who have widespread pain, it's not turning off, it's staying on. I had terrible anxiety disorder in my 20s and 30s. And I did not understand any of this. I just thought that I was being punished with all these painful conditions. I just didn't understand why other people got to live a normal life and I was living a life of pain, which I don't anymore. Praise God. Okay. So what the research shows is that for 80% of the children who develop widespread pain as an adult, there is a major physical injury in childhood. And I can still remember a gentleman I was working with who got hit by a car when he was like in 6th grade, and he was in his 50s, and he had struggled for years. Because when you get an injury, I mean, muscles are torn, bones are broken, but what happens to nerves? Nerves get sensitive. It might heal, but it's now sensitive. Hey, Cardsty, nice to see you. Nice to see you, hon. Okay. So 80% of the kids who develop widespread pain as an adult, they have a physical injury. But for the other 20% of us, it is a history of abuse or bullying. Now, in my case, I've shared my story many, many times. I grew up in a neighborhood with a young man who became a rapist and a murderer. And I was attacked constantly from 4th grade on. I lived in fear. A bunch of us were hurt. And the year I went away to college, he raped and murdered my neighbor. So my brain was in fight or flight every single school day. From the time I woke up, when my mom woke me up, said, got to go to school. Immediately I went into fight or flight because it was the walk to school and back where I was attacked constantly. Physically attacked, hurt. So what happened to my brain is that it recognized that my life was threatened, and it stayed there for decades. because it was a real threat. My life was absolutely in danger. And I lived knowing that I walked where the murder happened, and that could have very easily been me, gleefully me, because I was just a huge target. Not my fault, mentally ill. He was mentally ill. So think about what that did to my brain. I began to live in fight or flight every single day, every single minute of every day. My brain didn't know how to relax. It just didn't know how to relax. I didn't get it to relax until I took an anxiety management class when I was 35. So it's very, very important that you know that you are not alone. This is not your fault. You have done nothing wrong. If you have widespread pain, you are a trauma patient. Something happened. Could have been a physical injury. It could have been sexual abuse, like the patient I was working with on Friday who had a big history of sexual abuse when she was younger. Her anxiety was today, 50 years later, was off the charts. I mean, I really, it's heartbreaking to know that here was somebody else whose life was controlled by memories of trauma. And so for us, our treatment is focused on calming the central nervous system. And we're going to do that. We can do that with medications like gabapentin. We can do that with palmitoyl ethanolamide, which is a supplement. That's what I take. But it's also very, very important that we learn and we get those skills to bring our brain out of fight or flight, because you have to retrain it. You know how when you're an athlete, you train for muscle strength and you go lift weights, and you know over time your arms get stronger and stronger and your legs get stronger. Okay. That's exactly how we have to approach this nervous system injury. We have to work it. We have to train it. We have to teach our brain that I am now 50 years old. The trauma happened when I was 12. I am safe. I am in my own home. It will never happen again. My abuser is dead or whatever. The challenge is the brain remembers the trauma. We have to teach our brain with very, very specific techniques. We call these techniques mindfulness, that we're safe. We've got to bring everything out of fight or flight, because here's the deal. The way the brain processes pain is based upon your state of mind. A pain message goes to your low brain. That's the spinal gate that only lets the most important pain message through. It will then hit the midbrain, and the midbrain's job is to apply context. Is this important pain? If you're laughing because you're on a roller coaster and you get thrown to one side and you tweak your rib, well, you're laughing. Clearly, your life is not at stake. So your brain will minimize that pain. But if your pain is accompanied by anxiety and tears, your brain goes, oh no, this could be really bad. Your life could be at stake. Your midbrain accentuates the pain, increases the pain, because it's trying to get you to take action because it thinks your life is at stake. So think about it this way. Have you ever woken up in the morning and you feel awful? Like you just feel, and not just your icy, you just you feel like something's really, really wrong. And you decide that you're going to go to urgent care, or you're going to call your doctor and get into the doctor. Hey, I don't know what's wrong. I feel absolutely terrible. And then you drive there and you're sitting in the waiting room and you're just living in this world of, oh God, I feel so terrible. Then you get to see the doctor, and the doctor looks at whatever is hurting you and goes, oh, I know exactly look at that. You have got a really, really deep splinter in your hand. That's where the pain's coming from. It's not cancer. I can fix this right now. Or, oh, you know what? I think maybe you've got the flu. Anyway, The doctor gives you context. The doctor says, "Oh, this is really not a big deal. We can fix it." Bladder infection, if it's a bladder infection or anything at all like that. And all of a sudden, you go from being in agony to, "Oh, that's cool." And you walk out, and suddenly you actually feel a little better. I had, um my philosophy has always been if I'm worried about something, I want to go and ask the question so I don't spend the next 6 months worrying about something. It's like if there's something that I don't think is quite right in my body, like a spot or something like that, it's like I'm not just going to sit there and wait. It's like, can you just look at it and tell me what it is? And most of the time, it's fine. I was doing that same thing with my car. Believe it or not, I have um, a 2017 Nissan Rogue, and the battery died, and it was covered with precipitate on the leads. This is white powder, and AAA came out and they went, "Oh, this is a real problem, and you need to go get this fixed. And I'm going to give you a new battery." So we did that, and I've been driving now for a year, worrying, worrying about the state of these battery cables, and it's like every time I started the car, I was like, "Is it going to start? Is it going to start it?" Okay. So yesterday, I broke my own rule. Yesterday, I finally said, I just look at the freaking battery, and the battery was perfect. It's like, oh, you just worried about this for 6 months. There's no reason to worry about it at all. So anyway, for that widespread pain patient, those are the kind of things we just want to try to deal with. We want to bring down the worry. We want to bring down the anxiety. We want to retrain that brain and tell the brain that you're safe with some really good mind body medicine, taking anxiety management classes. I work with patients all the time on the phone. I've got really good techniques that we can do to break you out of fight or flight. We just have to be persistent. So to sum this up, we are so much more prepared and successful today working with IC patients than we were a decade ago. Because today we can find the actual underlying cause. And when we know the underlying cause, we can treat the underlying cause. And we're not condemning patients to be on bladder treatments that won't work for the rest of their life. And so this is a joyful time, because we've gotten so far, and you should be very optimistic about where we are today. So now the challenge, of course, is phenotyping is new. They were only hard written into our AUA guidelines 2 years ago. So the odds of your doctor knowing about phenotyping are slim to none. And so I have videos on our website. I have our masterclass, and I'm getting ready to put more episodes for the masterclass. I had to stop because, again, I was recovering from surgery. I've got a great video there on phenotyping. You need to watch it so that when you go to your doctor, you can start asking better questions like, are my muscles tight? Like I was talking to somebody today, as a matter of fact, I did a coaching earlier today, and the doctor found tight muscles, and she said, "Well, shouldn't we be treating that?" And he goes, "No, don't worry about it." But because she, watched one of these meetings, she went, "No, I think I really want to go to physical therapy." And he's like, "Okay." So anyway, well, let's go. Let's hit some of your questions here. I think you've heard enough of me. It's so nice to see you, Cards T. Mr. A says, "Is amitriptyline helpful for calming nerves down?" Yes, it is. Yes, it is. The challenge with amitriptyline, which is a low-dose antidepressant, which is often suggested for people with widespread pain, lots of different types of pain, a wide variety of pains, it's because it does act to calm nerves down. The problem with amitriptyline is it has fairly horrendous side effects. And so it's really hard to get patients to the most effective dose, which might be 50 milligrams, 75 milligrams, when 5 milligrams causes very, very dry mouth, weight gain, irregular heart rate, et cetera, et cetera. I did amitriptyline for 3 months and it permanently damaged my heart. Amitriptyline can affect the conductivity of the heart muscle. And so normally your heartbeat is a beep, 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 because that's the SA node and the AV node firing to give you your heartbeat. Well, amitriptyline for me, as confirmed by my cardiologist back then, turned on a third node. So my heart rate was beep, 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 beep. And let me tell you, my heart now is super sensitive because of that. Super sensitive. I constantly struggle with PVCs and the occasional arrhythmia, all from that amitriptyline 30 years ago. So if you have a rapid heart rate when you take Benadryl, the odds are you're not going to be able to tolerate amitriptyline. And it's very, very, very important that you understand that no medication should interfere with your quality of life. You should not be tolerating tachycardia to get this effect from this med. If you're struggling with severe tachycardia, that's not the medication for you. So you really got to read stuff. You got to read about the side effects, and you got to be fairly strong with your doctor and say, I'm not comfortable with it. So Cindy here on Facebook says, I've taken amitriptyline for 35 years. I have a heart murmur and I take metoprolol. I take metoprolol twice a day, Cindy. And Cindy, I got to tell you, girl, listen, I had my COVID vax a month ago and it, holy moly, did it mess my heart up. Like I went into AFib for the first time. And it turns out what the research shows is the more vaccines you get, the greater the risk of heart rhythm problems. So had I known that, I would not have had this COVID vaccine. And I'm not an anti-vaxxer. I'm a scientist. I believe in vaccinations. But I also, the mistake I made is I didn't look at the research, and I should have. There was no line. And I just thought, oh, I'll duck in and get my vaccine, not knowing that 12 hours later, the paramedics would be asking me if I wanted to be revived. Thank you, Cardstee. Mr. A said, I started amitriptyline 2 weeks ago. No side effects, only 10 milligrams. Aside from constipation, I guess, but I had that beforehand. So, take some time to just read about the side effect. The most common side effect is going to be dry mouth, dry eyes, and weight gain because you start snacking. We call it the Elavil 20. So it's a hard medication. And understand too that our American Urology Association guidelines, they actually, in the revision in 2014, they didn't want you to try amitriptyline until you tried the supplements first, because they didn't want you to do the things with the big side effects before you did the things with the little side effects or the fewer side effects. So as an example, when we talk about calming the nervous system, one of the best things that you can do is PEA, palmitoyl-ethanolamide. We had a research study in 2019 that was fantastic with the IC patient population. PEA has been studied extensively with a wide variety of painful conditions, from shingles to burning mouth, surgical pain, chronic pain, et cetera, et cetera. 2019, the European researchers did a study with IC, and the results were spectacular. And when that was presented at the big national conference, the doctors were very excited because they could finally prescribe something for pain that was not an opiate. So that's what I take. And what's amazing is all of my skin sensitivity is gone now. I mean, I'm still not going to wear wool or acrylic. That would drive me crazy, but I don't feel like I'm being poked by pins like I used to. So the PEA is So I took that study to this company that we work with, Natural Approach Nutrition, and I said, "Can you make us a formula similar to the formula used in the IC study?" And they did, and that's PEA 500, and that's one of our biggest sellers now. And the blessing here is that it's also one of the most inexpensive supplements. It's like $28 or $29 for a month supply or two, or if you take one a day, a 2-month supply. So if you suffer from widespread pain, this would be fascinating to try. And we've got the research to back it up. We've got the PEA study that proves that this can be helpful in calming nerves down in patients who struggle with a variety of painful conditions, including IC, etc. So that's over in the IC Network shop right now if you're interested. But I'm not here to sell you stuff. I'm here to answer your questions. I'm just giving you options. All right, so let's go back here. Christine says, what can one do that is not medication centered? The meds are too dangerous for some. So again, supplements. We really want to, but you remember there's old supplements and new supplements. We're phenotyping now. So really the supplement you choose is going to be dependent on your phenotype. So of the existing supplements that we have for patients with widespread pain, it's going to be PEA. For patients with Hunner's lesions, it's going to be lactoferrin because we have a fantastic study with lactoferrin, which is a simple over-the-counter supplement that was remarkably successful at reducing irritation and inflammation in the bladder. It made Hunner's lesions heal. And I can talk more about that if anybody has more questions about that. So anyway, for the Hunner's lesion patients, I'm suggesting lactoferrin now. For the estrogen atrophy patient, it's really going to be a chondroitin supplement like Bladder Builder, Bladder Rest, Cystomend, or Cystoprotect. For patients in flares, and you just need to chill your bladder out, that's when we go to aloe. But we're not really focusing on aloe so much anymore as a day-to-day thing because the bladder's not made of aloe. So its mechanism of action is really about soothing the bladder. So aloe's good for flares, but it's not our focus anymore, if that makes sense. Vesna says, okay. So Vesna is asking, James, is amitriptyline helping you? My son Philip is also living in England, has Hunner's ulcers, and now the doctor has prescribed him amitriptyline. That's a good choice for him because it's going to help calm the painful nerves down, but it's not going to fix the lesions. Because remember, lesions have now been connected to a virus. So I would be adding lactoferrin to that mix. And again, we've got the research behind that. That would be no side effects. Lactoferrin is a protein found in colostrum. It has natural antibacterial, antiviral, and antifungal effects. No side effects in the IC study, no side effects in the vast majority of patients. And even patients who are lactose intolerant seem to tolerate it well. That's what the company told me because there's not enough lactose in it to trigger a reaction. Mr. A said, you sent me an email asking what my pelvic physical therapist found. She performed an internal exam and she said that whenever I perform a Kegel, my muscles don't release. So what that means then is we're dealing with muscles that have been taught to be tight or are responding to something else that needs them to be tight, like a bad SI joint, a flexible SI joint, that muscle locks down to try to stabilize the joint. So the great news is you're at the physical therapist. Now we see that. Now you're a puzzle to solve. You're an anatomical mystery to be solved. So hopefully she's looking at your hips, your knees, your legs, your feet, et cetera, to try to figure that out. Getting back to Christine here, what can we do for hypertonic severe sacral muscle injury? Physical therapy. Physical therapy. That's where you need to put your money. Don't put your money in aloe. Don't put your money in other stuff. The single most important thing for that muscle patient to do is physical therapy because we have got to get these muscles to relax and release. We have got to restore blood supply. The challenge, of course, is your insurance company may or may not pay for it. That's where it gets a little tricky. Aaron says, my bladder pain goes into my lower left back, left hip, and left butt cheek. No pain down my leg. What phenotype is this? Well, honey, that's going to be pelvic floor. That's something to do with your so left lower back, left hip, left butt cheek. That's where mine is. So we've got something going on with your glute muscle or your piriformis muscle or an obturator muscle on the left side. Classic. Especially if you have something like scoliosis, like I have scoliosis, that does not help because above the waist, I'm tight on the right side. Below the waist, I'm tight on the left side because the way the scoliosis rotates one hip this way and rotates the other one this way. So we always want to try to understand body mechanics there and try to understand what is influencing and putting long-term forces on muscles. And that's going to be bones or scar tissue or other injuries like that. Aaron says, I have widespread pain, have almost everything you mentioned. Yeah, but remember the widespread pain is triggered by injury. So you're like me, you have both. You've got something going on your left side and you have widespread pain. Boria has a bad cold. I'm sorry, honey. I hope you're feeling better. That reminds me, I need to put out our article on bladder-friendly cold and flu remedies. So just to kind of give you, we did a fairly big survey several years ago where we asked patients what were the most bladder-friendly cold and flu remedies. Honey was number one by far. Doing anything with honey throat lozenges, hot water with honey, things like that. And then there were a variety of lozenges and stuff like Chloraseptic was the good sore throat thing, Chloraseptic spray, Luden, No, it wasn't Ludens. What was it? Anyway, I've got several articles over on the IC network website that talk about bladder-friendly cold and flu strategies. I'll have to get that out there. Lisa said, what was the natural remedy you take in lieu of gabapentin? This one, Peora. PEA, palmitoyl ethanolamide. I went back to, because I put together all the research studies for the AUA guidelines committee for male pelvic pain because I was trying to get them to add PEA to the guidelines. And I honestly don't know if they did or not because I had to have surgery and all that sort of stuff. But I put together all the research supporting it, trying to make the case that here we have something over the counter, simple, easy, with a proven record, dozens of research studies with an almost perfect safety profile. Why not encourage men with pelvic pain who have nerve-driven pain to give it a try? You got nothing to lose. Why put them on amitriptyline when we have something without the side effects? And there are prostate pain studies with PEA that were successful. Marlia says, I have everything possible. I walk like a duck. My hips are so tight. My knees hurt. My back muscles are like rubber bands. One leg is a different length. I don't think anything can be done at this point in time with my body. I'm 74 years old and a mess. Marlia, that's where you're wrong because muscles are beautiful. Muscles respond beautifully to physical therapy no matter what age you are. They really do. Muscles are very, 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 very trainable no matter what age you are. And so don't give up on physical therapy. And, the challenge is that as we get older, we start having other things going on that can certainly kind of mess with those muscles. But physical therapy, honestly, the more you move, the healthier you be. The more you sit, the worse, the weaker you get. We need you up and moving every single day. Like I did my walk this morning, even though I wasn't 100% this morning. Susan says, was Normast PEA? I don't think so, but let me look. Let me look. I don't remember. Yeah, Normast is PEA, but it doesn't have the combination of ingredients that were used in the ICPEA study. So I think it would be interesting to give it a shot again. Colleen, hold that thought here real quick. So, so Susan is asking the question, is Normast PEA? And the answer is yes. You don't remember it helping, but I'm trying your Pure now because IC is pretty bad. I never stuck to any of the drugs for very long due to side effects. So Susan, again, it's all about your phenotype, hon. Because if bladder treatments weren't working, what our national guidelines say, if treatments aren't working, stop what you're doing, take a step back and revisit the diagnosis. You need to be properly phenotyped so that we can try to figure out the underlying cause of your symptom. And I can do that on the phone with patients. I'm very, very good at giving you a new set of questions to ask your doctor to try to confirm what your phenotype could be. So you're welcome to call me. It's not a problem. Colleen says, how do you determine your phenotype, or is your doc? You can do a very good job of doing it if you just watch my video on phenotyping. Phenotyping is really easy. Concept number one is, for Hunner's lesion, has anybody looked in your bladder and seen lesions? If they had, okay, you're a Hunner's lesion patient. But if they've looked in your bladder and you've had a normal bladder or maybe a slightly red bladder, you're not a Hunner's lesion patient. We're going to throw that out. Our next phenotype, bladder wall driven, we're going to look at the quality and health of your skin, how old you are. That's going to help. Listen, if you're over the age of 50 and you develop IC symptoms, pretty much slam dunk estrogen atrophy case. We're also going to probe to see if you've gone through chemotherapy or you're doing anything caustic that would injure your bladder. For the pelvic floor, the easy way to distinguish if you've got pelvic floor is how you pee. Can you pee like a horse, or do you sit there and have to wait 5, 10, 15, 20 seconds? If you're waiting, your muscles are tight. Pudendal neuralgia is about you have pain when you sit down that gets better when you stand up, or positional pain. And then the widespread pain is, do you have super sensitive skin or wicked sense of smell? If you do, you have widespread pain. So phenotyping is actually really easy. Our challenge here is getting doctors to learn about the phenotyping so that they're doing it in clinic. The top doctors are. The mid-level and low-level doctors are not. That's why you've got to walk in knowledgeable and prepared and ready to ask the right question. Like I was working with a patient last week who, God, well, she was diagnosed like 6 months ago, and her symptoms were really just getting worse and worse and worse. And she could barely pee. She was even cathing to urinate. And I asked her, I said, well, has anybody checked your pelvic floor? And she said, no, never. And I said, then you have not had your proper and complete diagnostic workup. It's very, very important we get the muscles checked, because if you cannot pee on command like that, that strongly suggests that we're dealing with very, very tight muscles and an old injury. And the other thing that's just so interesting is so many of you, it's like when I'm working with you, it's like, all right, the question I love to ask is, how old were you when your symptoms began? And is there any event that you associate with the onset of your symptoms? Like, were you traveling? Had you fallen? Had you had a baby? Like, I had a patient who had her third or fourth baby, and she had a 3rd-degree tear this week. And she had very, very tight muscles. The traveling question is really, really important because I was working with another patient this week. I've been busy, guys. I have been busy. um, whose symptoms began after she traveled to like Uzbekistan. And in our magazine, our latest magazine, our IC Optus magazine, I always try to highlight those rarer causes of IC symptoms, and one of the rare causes of IC symptoms is bladder tuberculosis, which happens to be quite common in Uzbekistan or whatever country she was in. And so if your symptoms begin after traveling to the Middle East or to Asia or to like Indonesia, that area down there, we got to look at tropical diseases because you never know. So I was working with a patient who was swimming. She was in like Panama for a month, and they were doing all this rafting and tubing on the muddy rivers. And she had a parasite in her bladder. We can get parasites inside your bladder. You can get little worms inside your bladder. I know it's gross. Hey, listen, I went to Hawaii when I was 18 and I got a tapeworm. I recommend do not swim in brown muddy water, which is my cousins had me go on the slippery slide on Kauai, and it was brown green water, and I flew off the waterfall and on this like tube, and then you fall into the pond, and I swallowed a bunch of water and I got a worm. Let me tell you, there's nothing worse than being 18 years old and asked to produce a stool sample. I was so embarrassed, and it took us about 3 months to figure it out. So, tropical travel, you got to be careful. Um, let's see. Hold on a sec. Vesna says her son does better when it's sunny and dry. But if it's cold and rainy, I guess it's a little bit worse because weather is a stress. Whether it's extreme heat or extreme cold, that's a stress on the body. And when you're under stress, you're going to pee more. Mr. A says, I lived quite a sedentary lifestyle and then started doing intense ab exercises to try and get fit. This is the only thing I associate with the onset of your symptoms. But that's classic. But see, that's a classic onset that we see in so many people. One of the more interesting cases that I worked with like 2 years ago was a gentleman who was home with COVID. I mean, his office just closed. He had to work from home. He and his wife were working from home. And after about 6 months of sitting around, he like, I need to get fit. So he bought a bike, and a bike that you sit in and you work from or whatever. He wasn't out riding a bike. He was in his home with a stationary bike. And about 2 months later, all the IC symptoms began. He began having severe pain, et cetera, et cetera. And what it was an injury from the bicycle seat that injured his muscles and injured his nerves because, as he said to me, he was sitting on that for like 5 hours a day because he was desperate to get to exercise during COVID. And he ended up giving himself a big injury. So the challenge here, you've just learned a classic lesson that everybody learns. And that is when you start something new, you don't go whole hog. You have to understand that you haven't used those muscles in a while. So don't strain them by going really, really hard. It's a slow and gradual buildup. And we've all made that mistake. And I've made that mistake many times. Nancy says, do you have tips for getting out of a flare besides aloe? So Nancy, We have, if you go over to the IC Network website and you sign up for our free newsletter, you can download as our gift our flare management guide, which is 40 pages long. And I outline the four different types of flares that you can get. You can have a bladder wall flare, you can have a pelvic floor flare, you can have a stress flare, and you can have a hormone flare. And with each type of flare, I give hour by hour rescue plans. So please go on over to the IC Network website and sign up for our free newsletter. And I will tell you, I write that newsletter. I do not abuse it in any way. I don't sell our mailing list at all. I send out a blast newsletter maybe once every 2 months. And I send out clinical trial recruitments when they come in. So I'll be sending out one in November. And that's it. Colleen says, my 19-year-old daughter was diagnosed with IC 3 months ago, referred to excision specialist 2 weeks ago. They removed endometriosis, did a hydrodilation, which her bladder was not inflamed, and IUD replacement. She's been in pain every day, just spasming constantly, nothing working. IC doctor wants to do installations. I'm afraid it will irritate more. Finally, off in narcotics, gabapentin, aloe, Toradol, nothing works. She will be 2 weeks out of surgery Tuesday. Since Friday, she's been on imipramine, vaginal Valium, and Benadryl. So I'm lost. She's lost hope. Honey, Colleen, I want to talk to you and her. Let's get on the phone. I'd love to talk to you. Anytime we see symptoms begin in the teenage years, we're always looking first at injury, that there could be an injury and trauma to the pelvic floor in some way. If she was a gymnast, if she did sports, and there are a number of things that we look for in teens. Remember, mine started when I was 14, so I can totally relate. So there's my phone number on the back right there, 800-928-7496. Please call and let's have a chat. And if you can get her on the phone, I promise you I will make her feel better. Because right now she feels completely alone and isolated. She doesn't think anybody can relate to what she's going through right now. And we might be able to try to figure out what's spasming, because her bladder wall could be spasming, her pelvic floor could be spasming. Please give me a phone call. I'd love to talk to you both. Anne says, where's our video on phenotyping? Just go to the IC Network website, go to the self-help tab. I think the first link is our videos, or you can just go to our YouTube channel, which is youtube.com/ICN Jill. Rebecca says, will lactoferrin be beneficial for bladder wall subtype? I don't have Hunner's lesions. I had one glomulation on cysto. So Rebecca, number one, fantastic news. That means we're dealing with a healthy bladder. So the question then is, what could be driving your bladder symptoms? Now, the IC lactoferrin study was quite spectacular because so they took 31 patients with a history of IC flares, some with severe flares, some with mild flares. After a brief lactoferrin treatment of like 3 months, they went back, evaluated the symptoms, looked at their bladders, etc. 28 out of 31 had no symptoms. Their interleukin levels, which are inflammatory markers, were way down. But most importantly, their red irritated bladders had become pink and healthy, and Hunner's lesions healed and were not found. And so lactoferrin, again, this study was published last August, is an exciting new thing for patients who have a red, irritated bladder, etc. No side effects. I think it's like PEA, going to become a cornerstone now of treatment. That said, our challenge here is she has a healthy bladder. And so, yes, she's having bladder symptoms, but muscles can cause bladder symptoms. A lot of things can cause bladder symptoms. She could have a fibroid tumor pushing on her bladder. That could cause bladder symptoms. She could have tight pelvic floor muscles. That could cause bladder symptoms. There are a number of things that could trigger these symptoms. So now we've got to kind of expand our scope beyond the bladder to try to understand what could be happening. Nancy says, can you take PEA if you're taking Bladder Builder? The bottle on Bladder Builder doesn't say how much PEA is in it. Yeah. Well, the whole point of Bladder Builder is it's a kind of about saving money so that you don't have to take a bunch of supplements. They're all in one. And so the answer is if you're taking Bladder Builder on its own, and Bladder Builder is, in my opinion, the best supplement on the market right now for bladder wall-driven symptoms. You could add 1 or 2 PEA, but you don't necessarily need to. They kind of, when they formulated that, they knew that patients might want to take a little bit more. No side effects with the PEA. Really not worried about it. No known drug interactions. I encourage you to Google it and you look at it yourself. Don't believe me. You look at the research and see if you're comfortable with it. Elena says, I saw an ad today about FemiPro. Do you think it's good trying to restore good bacteria in your bladder? Let me look at it. All right, hold on. FemiPro contains unique ingredients designed to support a healthy balance of bacteria in the urinary biome, including the vagina, urinary tract, and bladder. Hello, the vagina is not part of the urinary biome. The vagina is part of the reproductive biome. I'm looking for the ingredients. What are the ingredients? If I can find the ingredients on their website. Like, I've never heard of this company before. $69 for a bottle. Woo, Betty, there's a lot of probiotics out there that are not $69 a bottle. Okay, hold on. Oh, no. For the IC patient, this is a hard no. So it has Mimosa pudica, which they say is anti-inflammatory. It has Uva ursi, which is used to treat UTI. So they're assuming that the reason why you need to take it is because you're dealing with bladder issues. But most importantly, it's got cranberry in it. It's got cranberry extract in it. And if it's not processed correctly, it could be quite acidic. So this is the type of bladder product where they're assuming that everybody has a bladder infection. And it makes no sense for those of us who have pelvic floor or widespread pain. If you have recurring UTI, then doing something that will prevent the growth of bacteria is important. I would be looking at lactoferrin, number 1, and I would be looking at that pink bottle back there, which is called Prevent. But it isn't something I would buy. I'm worried about the cranberry extra. It just appears that they're operating under the assumption that all bladder problems are driven by infection, and that's just not true. Anne says, you had to stop taking spin classes because of pelvic floor issues. Yeah, you should not be taking spin classes. If you are a pelvic floor patient, you should not be sitting on a bicycle, period. Hard no. The only thing you might be able to get away with is a recumbent bike, but a typical spinning bike, no way, no how. Honey, you already have a pelvic floor injury. That's like the worst thing you can do is sit on a bike seat like that. Thank you, Colleen. She says, you're a godsend. Honey, when we're done, you're welcome to call me too. Yeah, I'd be happy to talk to you today. And hold on a sec. I want to show you a picture. Oh, look at that. See, opened right to it. Okay, so let's look at this picture, shall we? So here we have a hard bike seat. And here, hold on a sec. Okay. And you can see right here the perineal nerves that the bike seat is pushing up against. And then this is talking about something else right there. No more bike seats, girl. No more bike seats. You're done. Listen, I grew up with horses. Horses are my happy place. Like if I could go do anything that I know would make me blissfully happy, it's just go hang out in a barn with a horse and smell the hay and brush them. That is my happy place. You could not pay me to sit on a saddle because I already have tight pelvic floor muscles and pudendal neuralgia. And the year that I broke my tailbone, I also was taking riding lessons and had a bad fall. So could that have played a role? Yeah, it definitely could have played a role. Hold on, my glasses are all weird with my hair. All right. Denise says, for me, it's a combination of things. I have IBS, fibro, I'm 68 and have to use hormone cream. My IC pain started with a bad UTI with Klebsiella and E. coli. I have no pain now. I stayed on a strict low acid diet. I go to pelvic floor therapy and take an antihistamine at night. Took about 4 months, but I'm doing good. Got my IBS under control too. Excellent. The pelvic floor therapy is really vital for you, hun. But Denise, the other thing you've got to pay attention to is you're 68. You are in estrogen atrophy. There are a group of women who get recurring UTIs because of estrogen atrophy. So, if you get 2 UTIs in 6 months, 3 UTIs in a year, you are called a recurring UTI patient. That is not a simple UTI. That is classified as a complex UTI. And what that research found is that about 24 hours before the bacteria arrived in the bladder, it was living quite happily in the vagina. So this then led the researchers to ask the question, well, wait a second, what's happened to our vaginal defenses? Why has the vagina become a safe haven for bacteria? And the answer goes right back to dryness from estrogen atrophy. And so therapeutically, in addition to giving you the antibiotic, they also want to make sure you're using a topical estrogen vaginally so that we build the vaginal defenses back up so it does not become a safe haven. Also, just so you know, last year, the lactoferrin researchers found that lactoferrin was very good at preventing recurring E. coli infection. So there are 2 separate things, potentially 3 separate things going on with you. You're doing great, fantastic, but we got to just be aware of these things. We want to keep your muscles nice and healthy. You're doing that. We want to keep your skin nice and healthy. So talking with that doctor about the quality and health of your skin, and if necessary, starting to use a topical estrogen. Well, you say you're using that. So that's very, very good. And then because you got the IBS and the fibro and some bladder sensitivity, that tells me that your nerves are kind of tweaked too. So if you're feeling like very, very sensitive skin, wicked sense of smell, that's telling us that your nerves are becoming a bit more sensitive. So doing something like PEA might calm that down. Hi, Tito. Ursula says, my doctor wants to dial down my nervous system and I'm in physical therapy, but I'm very sensitive to meds and have tried everything I've tried. Small dose of Xanax sometimes help me sleep, but I'm very groggy the next day. I'm frustrated because I wake. Okay, honey, again, I'm the same way. Come on, I have widespread pain too. And I hate taking stuff because I never know the side effects I'm going to have. And after menopause for me, because I'm 64, which is crazy, I started developing really, really sensitive skin. I felt like I was being poked by pins. And it got really, really bad. And then the PEA research came out, and I started looking at a bunch of PEA studies. And I saw its mechanism of action is calming nerves down. And I went, what the hell? I'm going to give it a shot. And no, I have had no side effects. Almost every study on PEA shows no side effects. There are no known drug interactions. And so this might be worth trying. I can't predict how you'll do, obviously, but it would be an interesting experiment that might calm some of your nerves down. I mean, I'm very grateful because I really had trouble sleeping for a couple of years. And it's just so not. And, I truly believe that it's helped me with my recovering from surgery also. All right, guys. Hey, you know what? Potty break. I need to go pee. I'll be right back. Everybody go use the bathroom and come on back. All right. I have returned. YouTube, I'm sorry, this camera is just being funky. All right. Now, y'all know I have no shame. I'm willing to talk about anything at this point in time. About 6 weeks ago, I decided to try a new high-protein yogurt. Oikos high-protein yogurt. Love the flavor of it. It was peach, etc. But something started happening that I didn't put it all together. I started struggling in the morning with more crampy bowel movements. And then I started feeling like I needed to stay home for about an hour or two, just in case I needed to use the restroom again. And it was getting a little annoying because I wanted to go do things, but I felt like I wasn't sure what my bowels were going to do. And it was starting to annoy me. And then finally, I went, I wonder if it's a yogurt. Shop the yogurt. I'm good, baby. It's gone. It's like, so it's so interesting how you do things because you want to get better. And it's a high protein yogurt. And I was trying to cut sugar and I loved it. But there was something in it that was giving me the runs. And I'm just so happy that I'm back to normal. Ah, anyway, like I said, I have no shame. I'll talk about anything. Elena said, I had a microgen test. They found out I have a bunch of bacteria there. Never found anything before. Thank you for the recommendation. What's the prevent? Let me get it for you. So prevent is like Allura, very similar to Allura, which is these are medications that combine D-mannose with proanthocyanidins to reduce the growth of E. coli recurring infection. It's not a treatment for an active infection, it's a preventative, but it's half the price. This is the biggest sellers for that company. And ironically, it was an IC doctor that asked them to make it and develop it. So if you struggle with recurring UTIs, prevent would be something that you could try, and you could find it on the IC Network website. Denise says PEA does help her. Nancy says, sorry if I'm redundant, but again, if I'm taking bladder builders, does that mean I don't need a separate probiotic? Yeah, you don't. I'm taking seed probiotics, but wondering if that's too much with the bladder builder. It all depends upon, I mean, it depends upon how you feel and how are your bowels doing and how's your bladder doing. So, I mean, I just shared that one yogurt that I thought was really, really good actually ended up bothering me. I switched back over to the original yogurt I was doing, and I'm fine. So yeah, this is kind of a try it and see how you do situation. Anne says, will PEA help the bladder frequency at night? PEA can calm the nerves down that are driving the frequency. Worth a shot. Marlia says, I too raised and trained show horses too, got thrown, and I have to wonder now that you mention it. But I really never had noticeable symptoms until I lost my partner in 2017. Stress to the max. I think it brought it all on, but who knows? I'm now 74. You're right on that note. Dry. You're very, very dry. It's so bad. You're using the estrogen cream. Every muscle in my body is tight and sore. I'm going to try the PEA and hope it doesn't flare me. It shouldn't flare you. I don't think I've had anybody call to say that it's flared them. I mean, we've been selling it since 2020. The IC study found no side effects or flares. So, see, Marlia, the thing that we track in patients with pelvic floor dysfunction and also in widespread pain, and I had a really long conversation for almost an hour and a half with Dr. Eckenberg last week, who is easily the best pelvic pain doctor in the country. I'm helping him edit his new book. And he reinforced to me, and then I'm going to reinforce to you, that what they see is a series of traumas over time that slowly damage nerves and muscles, which then end up making the nerves much more sensitive, which then amplify the nerve. So think about an electric guitar. Okay, if you want to make an electric guitar louder, what do? You either hit the string really hard, twang, or you plug in an amplifier. Well, your nervous system is like an amplifier for pain. The more sensitive your nervous system is, the more pain it transmits. It's amplifying pain messages. So what we have to do is we've got to calm those nerves down to get them to stop amplifying pain messages. So I would bet you $100 with your history riding horses, because I've worked with a lot of horseback riders. And I rode English. I was working with a patient who rode English in Western last week and had a really bad fall when she was younger. It's It's a lot of pelvic trauma over time that would have created the foundation for your very, very tight muscles now. But doing that physical therapy, girl, that's everything. That's everything. Getting massages, working on those muscles, really important. Mr. A says, my urologist said there was some inflammation of the bladder, neck, and bulbar urethra. He couldn't conclusively say that it was causing my symptoms. Do you think a muscle problem is more likely the cause? Well, I think you have to follow the data. You've got both. You got muscles that are screwed up, and remember, tight muscles cause inflammation. And so if we can work on those muscles and get them to release, it would be very interesting to see what that does for the inflammation in your bladder. The other concept here is that there's something else could be causing the inflammation, like you drinking a lot of soda or coffee or green tea, something like that. The inflammation could be a red herring. Cause and effect, cause and effect. It might be the effect of the underlying muscle problem. Jackie said, had an IC crisis in August this year. I stopped everything that put me worse. I stopped coffee a month ago, but I still have symptoms. How much time do you think I will feel better again? I used Elmeron, tolterodine, and Preleaf. Jackie, how old are you? Or Jacqueline, how old are you, hun? Need to know your age to answer that question correctly. So if you can give me your age, that would be very, very helpful. Ursula says she got an upset from PEA, but you'll try it. Wow. Okay, that's really, really rare. I totally believe you. I take it on an empty stomach before I go to bed. It's never bothered my stomach, but we're all different. Might be worth one more try, maybe with a little bit of food to see how you do. There might be another ingredient in it that might be bothering you specifically. Rice flour, if you have a problem with rice. I mean, it's just got vitamin D3, vitamin K2, calcium carbonate, a little bit of magnesium glycinate, high absorption PEA, and resveratrol. We had a new study with resveratrol that just came out that showed it was very good at reducing inflammation in the IC patient. So again, really good combination of ingredients here. Jackie is 53 because your menopause, and you started using estradiol because menopause started at 38. So is there any event that you associate with the onset of this flare? So if you go back to early August or late July, what do you think triggered this flare? Were you traveling? Had you had sex? Were you swimming, bike riding, under intense stress? Law, LA, what is that? LA, law. I'm not sure what that means. And honey, you're on a 2-second delay. That's why YouTube is always on a delay. So that's why you have to wait a couple seconds before you type again. I'm sorry. So what does law mean? I have no idea. Elena says, thank you very much. You're a blessing. Rebecca says, do you have any idea why air bubbles come out of my urethra after I pee? I don't have a UTI. No, I don't. I really don't. I mean, that happens to all of us. I don't know. That's a fantastic question. I honestly don't know. Okay, you planted a seed. The only time I've ever had bubbles coming out of my urethra was after a bladder installation or after a urethral dilation where they put something in my bladder. And the catheter or the cystoscope pushed air into my bladder and then the air came out. But great question, Rebecca. I'm not sure. Okay, Jackie says she thought her flare was triggered by a specific coffee. Okay, so girl, we gotta have the estrogen chat here. So you've been in menopause for 15 years, basically. So think about your bladder for a moment. It's the only organ in the human body designed to hold toxic waste, right? Because urine is body waste. Urine contains ammonia and urea and all sorts of irritants. So how can the bladder hold ammonia for hours at a time and not get damaged? It's a real evolutionary marvel because the way the bladder protects itself is with a really thick coating of mucus. And the purpose of that mucus is to act as a barrier. It's what we call hydrophobic. It pushes water, it pushes urine away from the skin and the nerves. So mucus is critical to how your bladder defends itself. Unfortunately, mucus production is estrogen dependent. So when you're young and have a lot of estrogen, you got a lot of mucus. But girl, you went through menopause 15 years ago, which means you don't have that same amount of mucus that you did have. Even though you've been using estrogen, you're never going to have a 20-year-old bladder again. So your bladder's ability to defend itself is greatly compromised after menopause. And drinking coffee, I mean, you went into menopause really young, and I'm sorry that happened because that's limiting you now. But you might not be able to drink coffee at this point in time. Or if you are drinking coffee, you need to drink a real low acid coffee. And the two brands that I recommend are, let me get them. Whoops, stay. Okay. So coffee acidity is determined by the altitude that the beans are grown at, when it's harvested, or the altitude, when it's picked, how it's roasted, and how it's brewed. So the worst, most acidic coffee beans come from specific altitudes. The best low acid coffees are picked at the correct altitude, and I don't remember what that is off the top of my head. Then they're, instead of being hot roasted in a metal drum, they're actually air roasted, which reduces the formation of acid. So Bella Rosa coffee is, according to research done by the University of California at Davis, has the lowest levels of chlorogenic acid in the industry. So I put this as the top low acid coffee. It comes in regular, decaf, and half calf. So if you're desperate for coffee, you have to do low acid. I would suggest that you start with the decaf. You really don't want to do regular coffee because that acts as a jackhammer to the nerves, and that's going to make you pee more. The second coffee that we suggest is Tyler's. He calls it the world's first acid-free coffee. But again, it depends upon how you brew it and all that sort of stuff. But this is popular too. So these are our top two low acid coffees, and you can find these in the IC Network shop. And then, of course, the other thing you want listen, if you don't have a choice, you're out with your girlfriends and you just want a freaking cup of coffee after a movie or whatever, bring some pre-leaf with you. Because if you take 2 pre-leaf caplets before you drink the coffee, that's going to take out 95% of the acid. And so pre-leaf is a great way to try to eat some of the things that you really used to enjoy, but you know it could irritate your bladder because of acid levels. So that works really well with tomato sauce, with coffees, with teas, etc. So I'm really glad that you stopped the coffee. The challenge here is you haven't gotten better significantly. Well, hopefully you've been screened for UTI. Hopefully you've been screened for tight pelvic floor muscles. That would be, you know, a requirement to really try to understand the type of flare you're having. And you just have to understand that you're just not going to have a young bladder anymore. So you might benefit from something that will give your bladder a little bit more defenses. So that would be a chondroitin-based supplement like Bladder Builder, Bladder Rest, Cysto Protect, or Cystomen. And one of the things the doctor can do is do a rescue installation with heparin and lidocaine. And what that will do is that will coat the bladder temporarily, and it will numb the nerves of your bladder that are screaming. So the protocol for a rescue install is like once a week for 6 weeks, or 2 or 3 times a week for 2 weeks, and then once a week for a month. And the goal here is to just keep turning the nerves off. The goal is to just silence the nerves over and over and over, hoping that over time the nerves will just slowly dial back down and calm themselves down a bit. I'm sorry that you're having a wicked flare, honey. We've all been there. You're not alone, my friend. You're not alone at all. You're very, very welcome. She says, it's been a blessing to find you. Thank you for all your info. I will try the pelvic exercises. So remember, it's not Kegels. You can't do it. You're not going to figure it out on your own. You have to go to a properly trained physical therapist at least once for a proper pelvic floor assessment, because they need to identify the muscle that's the problem. You'll never figure it out on your own. So you've got muscles on the left side, you've got the muscles on the right side, you've got shallow muscles, you've got mid-level muscles, and you've got deeper muscles. So when you go for a pelvic floor assessment, they're going to have you walk up and down a hallway. Let's see how you walk. Your ability to describe your symptoms gives them a roadmap on where to look. So don't just walk in and say you have IV. That's not helpful. You got to walk in and say, hey, I've got pain here. I've got pain there. This makes it better. This makes it worse. I might have pain shooting down my leg. I might have moments of sciatica. I might have pain when I sit down, etc. You want to give them a kind of a roadmap. They will ask to do an internal exam. That's the single most important part of the exam, because you can't reach these muscles externally. So what they're going to do is insert their finger in your vagina, or for men in your rectum, and all they're going to do is just palpate muscles. A healthy muscle feels like a raw chicken breast. It's soft, but it has substance. A tight muscle feels like painful beef jerky. It's tight and it's painful. And so they're going to go left side, they're going to go right side. Very quick, nothing to worry about. You're not in stirrups, nothing at all like that. But it's the single quickest way of determining to what degree your muscles are playing a role in your symptoms. And if they touch a muscle and trigger your pain, that is what I call your hallelujah moment. That's super, super exciting, because that means they found it. And your immediate response is, that's it. That's it. What are you touching? And hopefully they will then identify, hey, that's your left piriformis muscle. And then you can walk out of that meeting knowing the name of the muscle. Hopefully they will give you some exercises that you can do at home. But then you can also go to YouTube, because there are a lot of really good pelvic floor physical therapists on YouTube now. And so you can do like piriformis rehabilitation. Search for that on YouTube, and that will give you some ideas. But I really encourage everybody If money is an issue or it's not covered by your insurance, try to pay out of pocket once so that you can have that proper internal pelvic floor assessment, because that will at least tell us what we need to work on, what you need to work on. There's a fabulous website. It's pelvicrehab.com. Now, we have a doctor list and physical therapist list on our website, but really hard to all the lists are very hard to maintain, no matter where you find them. So you can look at the doctor and physical therapist list on our website, but you can also go to pelvicrehab.com and see who's close to you. They're both searchable by zip code. Sherry says, how long does it usually take for estrogen cream to help? You should start feeling some improvement in a couple of weeks to a month, but it might take 2, 3, 4 months to really get in there and saturate that tissue. You know, nothing happens overnight in the bladder. Nothing happens overnight in the bladder. It takes time for the bladder to heal. You have to be patient. Some patients stop their estrogen cream way too soon because they go, it's not helping. Or they go, it burns. I'm not going to do it again. Listen, if estrogen cream burns when you first start trying it, that's normal. And that means that your skin is very, very dry. The burning goes away. Every time you use the estrogen cream, the cells absorb some of that estrogen and they start to produce mucus. So that burning should slowly and steadily improve until it goes away. Now, if I forget to use my estrogen cream for a couple of weeks and I put it on, it'll burn again. But I know exactly what it is. That's a message. Hey, Jill, you're being a little passive aggressive. Use your estrogen. You got to keep your skin healthy. And I use very little of it, but my focus is my urethra, because that's where I feel estrogen atrophy the most. Diane says, does taking oral hormone replacement drugs help with the mucosal lining of the bladder? My mom took estrogen and progesterone from 73 years of age, and she's benefit of it. She's 84 years old, still doing great. My primary care provider doesn't want me to take it because I have high cholesterol. I'm going to go to a gynecologist. You know, honey, my mom was the same way. I mean, she took estrogen from her late 40s all the way through to her 90s. And they finally cut her off at like 92, mostly because it was just getting really hard for her to do it on her own because she had so much arthritis in her fingers. And even though I did a lot of her intimate care, you always want to give your mom, you know, decency, and she didn't necessarily need it. So anyway, the doctor, her gynecologist, decided that it's time for her to go off of it. Oral hormone drugs over the age of when you're over the age of 60 are associated with a much greater risk of cancer. The protocol for giving hormone replacement drugs now is if you're over the age of 45, if I remember correctly, if you're over the age of 45 and you're really struggling from menopause-related symptoms like hot flashes, they say, okay, you can use it for a brief period of time, a year or two. But they say once you're at the age of 60, they generally want to switch you to topicals because the risk of cancers are much, much higher when you're using oral meds. Now, when I was 51, 52, and I was struggling with a lot of muscle cramping that I associated with menopause. I mean, just all over my body. And so because my mother had taken it very, very successfully, I went to my gynecologist and I said, hey, you know what? I'd really like to try it. And they were like, fine, go for it. I loved being on oral estrogen. I mean, my skin was better. My memory was better. I felt great on oral estrogen until I started spotting. Like 3 years later, I started spotting. And it looked like pink lemonade. And of course, I reach out to my gynecologist. Hey, I got this weird discharge. It's this pale pink. He's like, yeah, you need to come in. We should do a biopsy. Let's make sure everything's okay. And of course, I let fear stop me from doing that. He's like, yeah, you're on oral estrogen. It's probably fine. You can wait a couple months. When I said, I don't really want to come in, he's like, okay, you can wait a couple months. Well, that pink spotting went from pale pink to dark pink to red to blood clots. So it started in August. By December, I was passing ginormous blood clots. And we get back in, and they measured my endometrium, which is the thickness of your uterine wall, and it was very thick because the estrogen was making it grow, but I wasn't having periods to slough it off. The problem is those thick cells sometimes become atypical cells, and those atypical cells sometimes become cancer cells. And to make a very, very long story short, it continued. We did a biopsy. I had complex endometrial hyperplasia with atypia and, quote, a vague architectural complex. They thought it was turning into cancer, and I had a hysterectomy. All from the oral estrogen. It turned out my uterus was fine. It did not have active cancer in it, but it had the equivalent of cancer seeds in it. And again, I asked my doctor why, because I've now had 2 bouts of estrogen-driven precancer and cancer. And they said, yeah, it's not genetics. You just have cells that just got turned on. And of course, now we know that sugar is feeding a lot of cancers. So I'm really trying to cut my sugar way, way, way back now. Interestingly, after I had my hysterectomy, another doctor said, yeah, you can go back on your estrogen now. And I went, no, now wait a second. You just scared the living daylights out of me the last year, and I endured a very painful hysterectomy. What are the chances I could get breast cancer? And he goes, don't try it. It's fine. Go ahead and take it. Well, of course, I didn't take it. I reached out to my gynecologist and said, my normal gynecologist said, do any patients who have uterine cancer, do they get breast cancer? And she said, yeah. Yeah, there's a group of women who get both. Hello. That would be me. Thank God I didn't go on the estrogen, and yet I still got breast cancer. So you got to be really careful with that oral estrogen. She's 84 years old, and I think you need to do a lot of reading about it and really sit down with her doctor about it, because at 84 years of age, it's much harder to recover from surgery like mastectomy. And so I would want to make sure that she's getting a mammogram every single year at a minimum, because the earlier you catch breast cancer, the easier it is to treat. But the reason why I chose to have a double mastectomy is I didn't want to wait 10 years and be 74 years old and have to have the other breast removed, knowing that I would be 10 years older and that it would potentially be hard surgery. I chose to have that done at the age of 64 when I'm comparatively young and strong. Nancy says, do most women use estrogen cream 3 times a week? Not necessarily. It depends upon your skin. Some people do it 2 times a week. Some people do it once. Some people do it 5 times a week. This isn't anything that anybody online can tell you to do, because somebody has to look at your skin. What does the doctor see? If your skin is very, 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 very dry, odds are they will have you do it once a day for 2 weeks. So 7 days a week for 2 weeks, and then go down to 2 or 3 times a week after that. That's a very normal protocol. But ultimately, you have to have somebody look at your skin to see where you are, to see what the right dosage is for you. Elena says, can I recommend a good estrogen cream? Well, it's just estradiol cream. There's 2 brand names, Estrace and Premarin. The challenge with the brand names is they tend to have more preservatives, which can be irritating. We tend to do better with a compounded preservative-free estradiol cream. That's what I get. I get mine from the Women's International Pharmacy. They're a mail order pharmacy in Arizona that specializes in creating estrogen for people who are very, very sensitive, like I am. They don't pay me to say that. That was my own gynecologist who said, we already know you're super sensitive. Don't waste your time on the brand names. We're going right to the best we can find. And the cool thing about the compounded estrogen, it's actually remarkably cheaper than the brand names. So, the brand name might be $200 for 3 months supply, or the compounded estrogen might be $50 or $60. Just understand that we've got to keep your skin healthy. It needs to be moist. You know how dry mouth hurts, dry vulva hurts, dry urethra hurts, dry bladder, dry vagina hurts. So we women of a certain age, we have to be very invested in keeping our skin healthy and moist. And using that estrogen is one way to do it. Another way to do it is with this is a great product, Vulva Balm. So if your urine feels like it's burning you, like it's hot and burning you, that's just estrogen atrophy on the vulva. Your urine is not burning you. That just means your skin is dry. And because you can only use the estradiol a couple of times a week, what do you do in the meantime? You do something like this. It's a very slight oil that really mimics your own natural mucus, very, very light. You can put this on a couple of times a day, preferably before you pee. That way, it's going to push the urine away from your more sensitive skin. So this Vulva Balm is fantastic and very popular with women who have estrogen atrophy. Love it, love it, love it. And this is in the IC Network shop. We also have, this is a new product from them. This is a pH balanced wash. If you struggle with infections and you just need something down there to maybe give you a little bit more cleansing effect, but it doesn't have any hormones, phthalates, parabens are a problem. Fragrance is a problem. Petrolatum, that's a problem. Dyes, soys, and it doesn't cause any irritation. So if you're looking for a little bit of a cleansing effect, you can go with their vulva wash. There was another really good vulva wash that was called Very Private. It was so good at eliminating bacteria on the vulva. So a lot of women who are struggling from recurring UTI were using it really successfully, but then it got bought out by its competitor and they shut it down so that the competitor would have the market. And I didn't like the competitor as much. So I love the Medicine Mama Vulva Balm Vulva Wash line of products. I think they're exceptionally good. Next week is going to be our little Halloween show, and I'm going to do something on what are the most scary things that you could eat. I want you to avoid the scary things in the IC diet. So I'm going to have a little fun with that. Rebecca says, how do we know if we need to use estrogen cream? Well, if you're dry, if you feel dry down there, I mean, you can wash your hands and touch yourself. Is your skin moist or is it dry? Does your urine feel hot, like it's burning you? But most importantly, when you go to the doctor or go to a good physical therapist, we just need somebody to look at your skin. They can see dry skin. Dry skin changes its appearance. You won't see it. they will see it. And so if they say that your skin is pretty dry, then that's when we would start using an estrogen cream. All right, guys. So hit me if you've got any more questions. Go ahead and hit me with your questions. Happy to do it. Otherwise, who was it whose daughter had IC? We can do a Zoom. I would be happy to set up a Zoom if anybody wants to go into Zoom and talk. Or for the Colleen, if you'd like to talk, we can talk today too. Your choice. Or next week. Your choice entirely. Nancy said, does the estrogen patch have the same warnings as oral estrogen? They have, okay. I just read an article on it. I think it was by Dr. Jennifer Gunter, who wrote the Menopause Manifesto. Now, I'm trying to remember what it said. Oh God, what did it say? It said something about the skin patch bypassed something. What did it say? Oh. Here, let me grab her book. Let's see if it's in her book. There are a couple of gynecologists that are really worth following on social media. And one of them is Jennifer Gunter, Dr. Gunter. And she wrote the Vagina Bible, or was it the Vagina Bible? What was it called? Yeah. She wrote the Vagina Bible, which is a great Christmas gift for any teenage girl. Please get them the Vagina Bible. And for those of us who have had hysterectomies or whatever, the Menopause Manifesto is, again, a fantastic book to really help you understand the chaos of reverse puberty. Y'all remember how emo your teenagers were when they were going through puberty? The anger, the tears, the wackiness. Well, ladies, when you go through menopause, you're going through reverse puberty. And those random weird spikes of estrogen drive the same things that happen to teenagers. You're going to feel more anxious. You're going to feel more emotional. You're going to have muscle cramps. You're going to have dry skin. You're going to have you name it. Listen, it's a journey. It's a journey we all get to share. And knowledge is power here. And so the Menopause Manifesto is just a great way. We don't sell it. You can just get it on Amazon. A great way for you to understand the wackiness that happens in your body. So let me just see if she has anything on the patch in here. I know I just read something. It's not under a patch. And of course, I don't have my reading glasses on. That's the other thing that happens getting older. Your eyes get all bonky. It's under menopause therapy. All right, hold on. I'm sorry, the light is just not very good. Oh, here it is. The whole section on breast cancer. Okay, whole section on choosing. Dose equivalents of different estrogens and their delivery systems. You can get it all in here. You can get it all in here. Colleen, why don't you go ahead and set up a Zoom right now if you want to do it right now. And I will give you my email address and you can just send me the invite. Rebecca says, I have fibroids and cysts and my estrogen goes super high, then super low, and I can't do my cream for my bladder. My doctor won't take the tumors out. Well, that's odd. Why won't your doctor take well, fibroid tumors are tricky because a fibroid tumor can be growing. It can start in the uterine wall and go inside. And so if you had a big fibroid tumor and you're trying to carry a baby, literally the fibroid tumor would take too much room and affect the baby. A fibroid tumor can be inside the uterine wall, or a fibroid tumor can go outside. It can start in the uterine wall, but then it can push outwards and push onto the bladder and push against the bladder. So, and size matters. If it's a little fibroid tumor, probably not that big of a deal. It depends upon its location, it depends upon its size, and it depends upon its symptoms. What's interesting is that your estrogen levels are going all over the place. I would, depending upon your age, I can't tell how old you are, the sister on your tubes. I think it might be time for a second opinion with another doctor. I mean, listen, if you're in severe pain from this, what are you supposed to do? If they can take out the tube that the cyst is on, I mean, our challenge here is, do you want to have children or do you already have children? There are a lot of things to factor here. So I think getting a second opinion is going to be really, really important, preferably from a university. Don't just, there's 3 levels of doctors: local, regional, national. The local doctors are the least experienced. The local doctors send their complex cases to the regional doctors. It's the regional doctors that are at the university. Or if you're like in Kaiser Permanente, you go to their regional pelvic pain specialist. But your case can be so complex, even the regional doctor might not be experienced in it. That's when you go to a national doctor. If you want to call me this week and tell me where you are, I might be able to point you in a direction. I might. I don't know. But I'm willing to give it a try. Okay, Colleen, my email address is icnetwork@mac.com. That's short for Macintosh computer. icnetwork@mac.com. If you want to send me that Zoom, oh, you're Kaiser? Okay, so Rebecca, here's the hidden secret. Now listen, I don't quite understand what's going on with Kaiser Permanente. I'm a Kaiser Permanente patient too. And listen, their emergency room, awesome. Their OR, awesome. Their primary care, awful. They are really struggling right now with having enough staff and being able to give appointments. And so, but the other really hard truth about Kaiser, you got to learn how to work the system and understand they have regional pelvic pain doctors. So if you're in Northern California, the regional pelvic pain doctors are in San Francisco. That's where you need to be. That's the way Kaiser works. is they have their specialists in different areas in different centers. So like I wasted so long trying to work. When my gynecologist, who was fabulous, retired, they stuck me with this young, cocky gynecologist who was ridiculous. And I finally was just like, I need a referral. I'm really not interested. I wasn't interested in working with her at all. And working with a pelvic pain specialist, fantastic. And it was a simple phone call, solved everything. So you can always ask for a referral to the pelvic pain specialist. Marlia says, so when I finish peeing and stand up, I often drip and feel like I need to pee a little bit more. Is this a tight pelvic floor? Well, that actually I call that milking the bladder. That's actually really common after menopause. I do that too every now and then. And that's actually a sign that the muscle's getting a little weak. And so it's a combination of things. It's a combination of things. Jackie said here, I experience another symptom during the day. My bladder hurts more. In the night, my symptoms are almost gone. Okay, now that's fascinating. Is there any explanation for this? Why during the day are my symptoms worse? So Jackie, really what that points to is muscles. Because for people with bladder wall issues, they're the exact opposite. They're usually okay during the day. They're usually much, much worse at night. So the fact that your symptoms are worse during the day when you're moving around, that really kind of points to muscles, girl. That points to muscles. That means that movement, sitting, is triggering your pain. So I would want you to have a pelvic floor assessment. But you also say you drink a lot of water to try to minimize the symptoms. Well, there's always a shot that you're over distending your bladder by drinking too much water. I mean, don't go to town. You can tell if you're drinking enough water by what your urine looks like. If your urine is dark yellow or brown, you're dehydrated. If your urine is clear, you're drinking way too much water and you're messing with your electrolytes. Your urine should be a pale, clear yellow. Mr. A says, your ears are also worse during the day. You can sleep through the night. If you can sleep through the night, you have a healthy bladder. So Mr. A, man, that points to your muscles again. Listen, if you can sleep through, any of you, if you can sleep through the night and you're not getting up to pee, you have a healthy bladder. Your symptoms are not being caused by your bladder. Your symptoms are being caused by something beyond your bladder, usually the muscle. So that's actually really, really good news. Okay, so Colleen, did you send me a link? I don't have one. If you call the phone number 800-928-7496, pick the second or the third extension. Here, hold on. Do I have my phone? Let me see if it's charged because it's a weekend. We're good. So if you want to call, that's fine. I will. I'll give you 10 minutes to call. If I don't hear from you, call me on Tuesday. Okay, not a problem. I won't take it personally. I've got some other stuff that I want to go and do this afternoon too. Jackie says, "Oh, whoa. Well, I live in Puerto Rico. I'm not sure if there is any doctor, physical therapist. Let's look, hon. I have access to a really good database. Hold on. Let's see what's in Puerto Rico." Yikes. I'm sorry. There are none in Puerto Rico. Oh, that's heartbreaking. I don't see a single physical therapist in the entire Caribbean. The closest physical therapists are in Miami, and there's a bunch of pelvic floor certified physical therapists in Florida. Oh, honey, I'm so sorry. I would encourage you, if you can, buy this book, Breaking Through Chronic Pelvic Pain by Dr. Jerome Weiss. This will teach you everything you need to know about the pelvic floor. And it will give you a lot of case studies and success stories. So if you're in an area where there's no physical therapy available, get this book. Start with this book, because knowledge is everything here. And then based upon what you read in this book and kind of intuit about your symptoms, then it would give you ideas on the types of videos you might want to watch. But you can't just go watch a video on the pelvic floor. I mean, of course you can. I mean, I encourage you to do that, but you got to know more than just watching a 5-minute video. You got to learn about this. And when you read success stories and the history of patients and all that sort of stuff, it'll really help you. So, all right, my friends. Well, I think that we're done. As always, during the week, 800-928-7496. Feel free to call the IC network. I have a team of staff who answer the phone. And I answer the phone too, usually after 2:00 in the afternoon. I'm on a first come, first served basis. So whoever calls first gets my time. Please know that I return phone calls at like 4 or 5:00 my time, which on the East Coast might be 8:00 your time. Because I do my grunt work in the morning and then I do my phone calls later in the afternoon. So if you call and you get my message, just know that that just means that I'm working with another patient. So please just leave a message. And I promise we will connect eventually. Please be the squeaky wheel. Don't hesitate to call back a couple of times. It's helpful. But just be respectful of the fact that I'm also recovering from major surgery. And so I have days when I feel good and days when I don't. And if I'm having a rough day, I might not return phone calls that day. Things, the girls are gone, but the incisions are there, and they're big, long, painful incisions in my chest. Okay? All right, so I'm going to say goodbye to Amazon. See you later. I mean, not Amazon, YouTube. I'm going to say goodbye to YouTube. I'll see you guys later. I'll see you next week.